Okay, so lochia almost runs for 21 days during the puberty. Now, if it if this goes beyond, that means if this goes beyond 21 days or 3 weeks, then it suggests that there can be local genital lesion. There can be local genital lesion. Okay, and these are the stages or phases of lochia, rubra serosa alba. Okay, this is about lochia. Next question: the most common site of puerperial infection is placental. Infection of the genital tract that occurs as a complication of delivery is termed as puerperial sepsis. So infection of genital tract that occurs as complication of the delivery. Sources of infection may be endogenous, where organisms are present in the genital tract before delivery. The sources of infection, it can be endogenous. How it can be endogenous? Because organisms were already present in the genital tract before delivery. So if there is genital tract organism or genital tract infection and then delivery occurs, if there is genital tract infection and then delivery occurs, there is a probability that there will be puerperal sepsis, and this sepsis is endogenous. This sepsis is endogenous organ caused by endogenous organism, because the organism was already present, and this caused the sepsis. So it is generally a wound infection. Now why it caused? Because there will be a wound during the delivery. If there is wound, this sepsis has the most chance to occur, and the placental site will be in this site there will be wound, because the delivery of the placenta has to be done, and the portion where placenta was joined, that portion will have a natural wound. So that is why placental site is the most common site. Placental site is the most common site where puerperal infection occurs. So placental site, being a raw surface in the endometrium, is the most common site for infection. And this raw surface or uncovered surface, not covered by endometrium, right? So how it happened? Because during the delivery of the placenta, that that placental covering has to be removed, and the an endometrium and placental the root of the placenta, or the place where the placental site will have, and automatically there will be a wound in every cases. And that's why if there is genital tract infection, that placental site will be infected, or will have infection, puerperal sepsis. Now, other causes of sepsis, puerperal sepsis, may be laceration of the genital tract, or maybe CS section, cesarean section, wound infection by organisms like anaerobic streptococcus, E. coli, staphylococcus. Anaerobic streptococcus is the most common cause of puerperal sepsis. Very important point. The primary sites of infections are uterus, perineum, vagina, and cervix. Okay. Okay. Next question. Okay. Next we have puerperal pyrexia. Okay. Rise of temperature reaching 100.4 degree Fahrenheit or 39 degrees Celsius or more on two separate occasions, measured on two separate occasions at 24 hours apart at least, excluding the first 24 hours after the delivery, within the but within the 10 days following the delivery, is called puerperal pyrexia. So what are the criteria of puerperal pyrexia? Number one, temperature should be 39 degrees Celsius, more than equal to 39 degrees Celsius, measured on two separate occasions. Two separate occasions, excluding the first 24 hours. More than so, after 24 hours of the delivery, you must after 24 hours of the delivery you have to measure, but within 10 days of the delivery. 10 days after the delivery, following delivery. At that time, there should be fever. In this portion, there should be fever. And that also measured on two separate occasions. And these two separate occasions has to be 24 hours apart. Causes of the pyrexia: puerperal sepsis, urinary tract infection, mastitis, infection of cesarean section wound, pulmonary infection, septic pelvic thrombophlebitis. These all can be the causes of pyrexia. Okay, next question: which of the following is the cause of amenorrhea in lactating mother? Cause of amenorrhea in lactating mother. Okay, increased release of luteinizing hormone, increased GnRH secretion, hyperestrogenic state, increased prolactin level. And the answer is increased prolactin level. So breastfeeding increases the levels of prolactin, as you know, which lead to the following consequences. Number one is reduced ovarian response to FSH, leading to hypoestrogenic state. Suppression of LH, thereby preventing LH surge and inhibiting ovulation, and reducing GnRH secretion. So everything is on reduction. Okay, reducing the reduced ovarian response to what? To which hormone? To FSH. And obviously, if ovarian response to FSH decreases, then estrogen, leading to hypoestrogen, will not get secreted. Suppression of LH, luteinizing hormone. So LH suppression leading to prevention or prevention of LH surge. No ovulation. No LH surge, no ovulation. Reduced GnRH secretion. 3 reductions. And that's why in a lactating mother, amenorrhea occurs due to increased prolactin. Because breastfeeding, in lactating mother, there will be breastfeeding. And this breastfeeding will lead to increased prolactin secretion. And increased prolactin will cause these effects which are desirable during that time. These are desirable changes during this time of lactation. Okay, next question: a pregnant patient after delivery presented with hemorrhage. Pregnant patient after delivery presented with hemorrhage. Immediate hysterectomy is done in preeclampsia, rupture of uterus, atonic uterus, inversion of uterus. So immediate hysterectomy has to be done when there will be uterus rupture. So a pregnant patient after delivery presenting means after delivery hemorrhage after delivery, Now the question is whether to do immediate hysterectomy or not. So postpartum hemorrhage, this is called postpartum hemorrhage, right? PPH. Now postpartum hemorrhage has been defined as the loss of 500 ml of blood or more, minimum 500 or more, after completion of the third stage of labor. Although all these questions are objective type, but you must remember the definitions, because this 500 minimum 500 ml of blood, this you have to remember, or more minimum equal to. There is a question, very common question, how much pph is defined, is called when loss of how much amount of blood, loss of minimum 500 or more, obviously minimum 500 ml of blood. Another thing is, after, this is number one. Second point is after completion of third stage of labor, third stage of labor. So according to the given case scenario, ruptured uterus is the only indication to do immediate hysterectomy. Other options are like preeclampsia, atonic uterus, or involution, inversion of uterus, involution of uterus present with post-delivery hemorrhage, but they are not an indication of immediate hysterectomy. In these cases, preeclampsia, atonic uterus, involution, we do not have to go for immediate hysterectomy, and they can be first managed conservatively. But if uterus rupture occur, then we go for hysterectomy immediately without any conservative or any other type of treatment. Now in preeclampsia, there will be, what happens, because of the contractile nature, poorly contractile nature of the lower uterine segment, there may be uncontrolled hemorrhage following the placental removal. When bleeding is not controlled, then first we start with conservative means of controlling the bleeding. Then also, if bleeding is not controlled, then we go for overswing, suturing the implantation site, bilateral internal iliac artery ligation, or we can go for uninterrupted chromic sutures. Uninterrupted chromic sutures can be used. If such conservative methods fail, then bleeding is brisk bleeding, then we will go for hysterectomy. So this is in preeclampsia. So in preeclampsia, you must remember what happens. In preeclampsia, first of all, we need to know that there will be poor contractile nature of the lower uterine segment. And there may be uncontrollable hemorrhage following the placental removal, after removing the placenta. So first we go for conservative means. Number two, if it is not controlled, then we go for suturing the implantation site. And number three, bilateral internal iliac artery ligation. So arterial ligation. And number four, ligation or uninterrupted chromic suture is the next best choice. We can, under this, we can go for uninterrupted chromic sutures. If everything fails, then we go for hysterectomy. Then only we will go for hysterectomy. Otherwise, we'll stay with number one, number two, number three. Okay, next is uterine atony. Atonic uterus is the most common cause of obstructive hemorrhage, managed initially with oxytocin, so that there will be, if oxytocin is given, what will happen? There will be contraction, rhythmic contraction of the uterus, or prostaglandin analogs can be given, rhythmic contraction. If there is no effect, then we will go for no. Then we will go for hysterectomy. Inversion of uterus, in this also, inversion of uterus, in this also what happens? It is associated with immediate life-threatening hemorrhage. Most often it is associated with immediate life-threatening hemorrhage. So now, recently inverted uterus with placenta already separated from it may often be replaced simply by pushing up on the fundus. Simply by pushing up on the fundus with the palm of the hand and fingers in the direction of the long axis of vagina, followed by fluid infusion and blood transfusion. If no relief of then reduction via laparotomy is performed. This is about the inversion of uterus, involution. So first we start with pushing up. It's different from preeclampsia. First, in involution or inversion, we start with pushing up. Simple, pushing up on the fundus with palm of the hand and fingers in the direction of the long axis of vagina. Then fluid infusion plus blood transfusion, plus fluid infusion and fluid plus blood. Okay, fluid infusion, fluid and blood transfusion. If no relief, then reduction with laparotomy. No relief, then reduction with laparotomy can be done. This is about inversion. Okay, next. Okay, next question. During delivery, there is a perineal tear involving the anal sphincter, but anal mucosa is not involved. Which is the degree of tear? 1, 2, 3, 4. And the answer is 3. So, during delivery, there is a perineal tear involving anal sphincter, but anal mucosa is not involved. So, anal sphincter is involved but not mucosa. So perineal tear can be classified into 4 degrees. 4 degrees. First degree, second, third, and fourth. So first degree is the laceration of the vaginal mucosa and the perineal skin only, but not the fascia of the muscle. So vaginal mucosa and perineal skin laceration. Second degree involves the vaginal mucosa, perineal mucosa and perineal skin and fascia and muscles of the page. Just in first degree, there was no involvement of fascia and muscle. In second degree, plus fascia and muscle, plus muscle. Third degree involves the vaginal mucosa, skin, perineal body, and the anal sphincter. So mucosa, skin was there, plus perineal body, plus anal sphincter. In addition, the rectal mucosa is also shown. Rectal mucosa. Rectal mucosa. In fourth degree, rectal mucosa. Everything plus rectal mucosa. Okay, so these are the classification of perineal tears. Okay, next question. Most common cause of first trimester abortion. Very important question. Trisomy, monosomy, triploidy, tetraploidy. So first trimester abortion, trisomy. Trisomy. So approximately 50% of miscarriages during first trimester approximately 50% of the miscarriages during first trimester are anembryonic. Other 50% are embryonic miscarriages. Anembryonic with no identifiable embryonic elements And embryonic means displays a developmental abnormality of the zygote, embryo, fetus, or placenta. So 50% embryonic miscarriages, 25% of all abortion are aneuploidy abortion. That means out of this 50% of embryonic miscarriages, 25% are all abortion are aneuploidy. 25% are aneuploidy abortion, that is abnormal due to abnormal chromosome number, and remaining are euploid or euploidy. Remaining, that means next 25% is euploidy or euploid cause, that is abnormal chromosomal development. Euploidy is due to abnormal chromosomal development, and aneuploidy is due to abnormal chromosomal number. And this constitutes 50% of embryonic miscarriages. So the most common cause of first trimester bleeding is abortion. Very, very important point for FMGE. Very recently, many a times this question came. 2017-18, most common cause of first trimester bleeding. With respect to first trimester abortion, 75% of the abortion takes place before 16th week, and out of this, about 75% occur before the 8th week of pregnancy. Chromosomal abnormality in the conceptus is the commonest cause of miscarriage. Number one, very important point. Another important point is autosomal trisomy, particularly trisomy 16 is the most common cause of spontaneous abortion. So most common cause of spontaneous abortion. Very important. Autosomal trisomy, particularly trisomy 16. Trisomy 16. In inevitable abortion, uterus size equal to age of gestation, cervix is open, or uterus size is equal to age of gestation, cervix is closed. Uterus size small to age of gestation, cervix is open, small to age of gestation, uterus size, and cervix is closed. So what we are talking about, inevitable abortion. Inevitable abortion, and the answer is uterus size will be small to age of gestation, and the cervix will be open state. So first of all, in inevitable abortion, condition is progress to a stage from where continuation of pregnancy is simply not possible. That is inevitable abortion. Patient usually present with bleeding per vaginal bleeding with size of uterus smaller than the age of gestation and open cervix. So this is very common thing in inevitable abortion. Number one, bleeding, pervaginal bleeding. Bleeding means pervaginal, obviously. Number two, smaller size of uterus with respect to age of gestation, and open cervix. Open cervix. These three features are characteristic of inevitable abortion. Now, Inevitable miscarriage or abortion is a clinical type of abortion where the changes have progressed. Changes have progressed to a state from where continuation of pregnancy is not possible, increased vaginal bleeding, aggravation of pain in the lower abdomen, and dilated internal os. Very, very important, these clinical features. So treatment, if it is before 12 week, then we will go for dilatation and evacuation, followed by curettage using analgesia and under general anesthesia. Okay, if this is before 12 weeks. After 12 weeks, product of conception already formed, so product of conception is evacuated by oxytocin drip. If oxytocin drip is given, what will happen? There will be uterus contraction. Rhythmic contraction of the uterus will expel the product of conception spontaneously, and which increases uterine contraction. Okay, so product of conception will be expelled. So after 12 weeks, we will go for oxytocin. But if it is before 12 weeks, then DE followed by curettage. DE means dilatation and evacuation followed by curettage. Alternatively, we can go for suction evacuation. So alternatively, suction evacuation is there available followed by curettage. Can also be done before 12 weeks. This is also, this alternative method is also for before 12 weeks. Okay. So these are the types of abortion. Very important, very important. This for FMG, this is very important. Anything can come. Like in threatened abortion, what happens? Size of the uterus is equal to age of gestation. So, age of gestation. And for missed abortion, incomplete abortion, complete abortion, in all these three cases, the uterus size will be smaller than age of gestation. In all of the cases, cervical os will be closed. And in threatened abortion, remember, there is only threat, but the mishaps or mishappenings has not occurred yet. That is, the fetus is still alive. Just only threat. So bleeding occurs, but fetus is not expelled out. In case of missed abortion, fetus will be dead. In incomplete abortion, there will be products of conception will retain products of conception will be there in incomplete abortion. Complete abortion, product of conception will be expelled out. Expelled out and uterine cavity becomes empty. This is complete abortion. So here only threat, the misoccurrence has not occurred, the accident has not occurred, so fetus is alive. Dead fetus, missed, but fetus is dead. Missed, fetus is dead, but not expelled. Not expelled. Incomplete, incomplete means incomplete abortion, incompletely expelled. Incompletely expelled. Dead plus incompletely expelled. Complete, completely expelled. Completely expelled. So abortion is completed in this type of abortion. Okay, so starting with this, ending with this. Sequentially, we have classified the abortion. Any of the abortion, all of these informations are very, very important. For MTP, medical termination of pregnancy, which of the following drug dose is used? Which of the following drug doses is used? Very important question again. 200 mg. So 200 mg mifepristone, 400 mg misoprostol. So combination of mifepristone, misoprostol, or mifepristone and misoprostol. So which one of these? Let's see. 200 mg mifepristone and 400 mcg misoprostol. So following are the indications of termination under MTP Act. To save the life of the pregnant woman, first of all, what are the indications for MTP in India, legal indications? Number one, if there is a need to save the life of mother. For example, grade 3 and 4 cardiac disease, malignant hypertension, chronic glomerulonephritis, cervical or breast malignancies, all this. Next social indications like the physical or mental health of the pregnant woman is not suitable enough to have pregnancy or delivery. Humanitarian ground like cases of rapes or incest. Then eugenic like substantial risk of the child being born with serious physical and mental abnormalities so as to be handicapped in life. So if there is risk that the child who is about to born can have physical or mental abnormality, this can also form the ground of MTP. Termination is permitted up to 20 weeks of pregnancy. When the pregnancy exceeds 12 weeks, opinion of the two medical practitioners is required. Now, as we know, this MTP law is about to change. Okay, about to change. If it okay, so this law is about to change, and this 20 weeks is about to become 22 weeks, but it is not yet implemented. As of 11th May, is not yet implemented. But it will be soon be implemented. So this 20 weeks will become 22 weeks. And if this implementation comes before exam, we should choose 22 weeks. Otherwise 20 weeks. And this is very, very important. That's why we need to be alert that whether it's changing or not. If it changes, then we must choose that type of option. Means That means the 22 weeks and not 20 weeks. Okay. So the termination is now, as of now, it is 20 weeks only. And if this bill comes, then it will become 22 weeks. So when the pregnancy exceeds 12 weeks, opinion of 2 medical practitioners is required. Otherwise, 1 medical practitioner. Now, medical methods of first trimester abortion can be done by 200 mg mifepristone orally is given on first day. On day 3, misoprostol misoprostol, that is prostaglandin E2. This is prostaglandin E2. 400 microgram orally or 800 microgram vaginally. This is first trimester abortion. Okay, so on day 1, 200 milligram of mifepristone, 200 milligram mifepristone, 400 mcg microgram, that is a microgram of misoprostol. If 400 is used, then 400. If orally is used, then 400. But for vaginally, 800. Okay. So this is first trimester abortion. Okay. Next question: dangerously low-lying placenta is type 1, type 2 anterior, type 1 anterior, type 2 anterior, type 1 posterior, type 2 posterior, and the answer is type 2 posterior. Placenta previa. Placenta previa is what? It is used to describe the placenta that is implanted over or very near the internal cervical walls. Some of the possibilities are total placenta previa, number 1, partial placenta previa, number 2, number 3, marginal low-lying placenta, number 4. So total placenta previa means internal os is covered completely by the placenta. So placenta is not in the fundus, not in the normal position. Instead, not here. Instead, placenta can be here. Low-lying means more low-lying. So total placenta previa means internal os is covered completely by placenta. That means placenta is like this. And the internal os, this is the internal os. This internal os is covered by placenta. Now, if it if it is like this, so partial covered, that is partial placenta previa. Marginal, only the margin of the internal os is covered, then marginal placenta previa. Low lying, that means not covered, just low lying. Low lying placenta is implanted in the lower uterine segment, such that the placental edge does not reach the internal os, but very close to it. Very close to it. Now, low-lying placenta type 2 posteriorly located and is considered dangerous because it can compress the presenting part of the head, presenting part of the fetal head during delivery. Presenting part of the fetal head during delivery and will cause severe fetal asphyxia and death. At the posterior wall of the uterus, low-lying placental type 2 posteriorly located, it is posteriorly located. Why it is dangerous? Type 2 low-lying placenta, This type 2 low-lying placenta Type 2 posterior, posterior type 2, anterior type 2 is also there. Anterior there is not so much problem, but type 2 low lying placenta, if it is in the posterior wall, what happens? There will the presenting part of the fetal head will be compressed. Fetal head or the fetus, we can say fetus, presenting part will be compressed. Presenting part of fetus will be compressed. And if it compresses, then there can be asphyxia, fetal asphyxia leading to death. Okay, so that's why type 2 posterior low lying placenta is dangerous. Vasa previa, what is vasa previa? Fetal vessels course through the membranes and present at cervical os. That is vasa previa. Okay, the images are given: marginal, low lying, complete, partial. So in placenta previa, as part of the conservative management, we follow McAfee and Johnson regimen. This consists of complete bed rest. So what is this McAfee and Johnson regimen? Bed rest, tocolysis, close observation, strict observation. Steroids are generally given to enhance lung maturity. Steroids can be given for lung maturation. To undertake this regimen, all three criteria should be fulfilled. Number one, mother should be hemodynamically stable. There should not be any blood loss or like that, or anemic. Must not be anemic. Should be hemodynamically stable. There should be no fetal distress. Pregnancy less than 36 weeks of gestation. Age of gestation must be less than 36 weeks. If any of the criteria is not met, then patient should be delivered by lower segment cesarean section, LSCS. Classification of abruption placenta. First of all, Juspin regimen for the treatment of eclampsia using magnesium sulfate. As you know, treatment of eclampsia, we go for magnesium sulfate. Other regimen using MGSO4 for the treatment of eclampsia are Pritchard's regimen and Sebai regimen. Most appropriate treatment of eclampsia is magnesium sulfate, and placenta previa, placenta located at lower uterine segment. One of the most common cause of So placenta previa, placenta located at LUS means lower uterine segment. One of the most common cause of antepartum hemorrhage. Very important in case of centrally located placenta previa, mode of delivery should be cesarean section. So must be remember this for McAfee and Johnson regimen. These are the criteria. In which patients you will choose McAfee and Johnson regimen. These are the criteria. So if the mother is unstable, if there is fetal distress, or if the PP means placenta previa's degree, major degree of PP is type 3, that is incomplete or partial, or type 4, complete or central, then we go for cesarean section as management option from placenta previa, cesarean section. So these are the criteria when we will go straight to CS. These are the types. Type 1, low-lying vaginal delivery. Type 2, vaginal, marginal vaginally, placental anterior and CS. If vaginal delivery, if placenta is anterior. But if the placenta is posterior, then we will go for CS, cesarean section. Because we know that if placenta is in posterior section, there is a, it is little bit of dangerous. Why? Because presenting part in the placenta, if present in the posterior wall of the uterus, it is dangerous, because the presenting part of the fetus will be compressed, leading to asphyxia and death. There is a probability of asphyxia and death. So if placenta is present in the posterior section, posterior wall of this uterus, we'll go for CS. Type 3, incomplete or partial, always cesarean section. Type 4 also. Type 3 and type 4, remember, we will go for CS. Type 3 and type 4 is a clear indication, of cesarean section. Or if fetus is in distress or mother is unstable, then we go for CS. And for conservative management, what is the McAfee protocol? McAfee protocol for conservative management is bed rest, monitoring the vitals, blood transfusion if needed. This should be done when this should be done when the age of gestation is less than 34 weeks, and we should also give betamethasone 12 milligram. 12 milligram IM 2 dose 24 hours apart. 2 doses. Okay, 12 milligram. In between there should be 24 hours gap for lung maturation. Betamethasone steroids. Okay, so this is about this low-lying placenta previa. Placenta previa, very important topic for FMG. All these are very much high-yielding informations. Must remember these indications for conservative management, indications for termination by vaginal delivery or CS. Okay. Okay, next question. Recurrence of hydatidiform mole is assessed by AFP level, beta HCG level, LDH level, estrogen level. And the answer is beta HCG level. So recurrence of hydatidiform mole is assessed by beta HCG level. Hydatidiform mole, they are abnormal pregnancies characterized by molar pregnancies. We call it molar pregnancies. Abnormal pregnancies characterized by histologically by the aberrant changes within the placenta. Specifically, the chorionic villi in this placenta show varying degrees of trophoblastic proliferation and edema of the villus stroma. So the chorionic villi in this placenta, what happens in hydatidiform mole? First of all, that you have to remember is there is some changes, some aberrant changes in placenta. Aberrant changes or abnormalities in the placenta in hydatidiform mole. Specifically, now what are the apparent changes? There will be trophoblastic proliferation. And edema of villus stroma. There are two types, partial and complete. Partial and complete. So partial mole, there will be swelling of all placental villi, while in case of complete mole, molar pregnancy, there will be normal and some swollen villi plus fetal cord and or amniotic membrane elements. So in molar pregnancy, in complete mole, there will be normal and swollen villi. Additionally, there will be fetal cord or amniotic membrane elements as well. In case of partial mole, fetal tissues will not be there, while case of complete mole, fetal tissues are present. You also see the changes or the difference of karyotype. In case of complete mole, villus edema is diffuse. Typical clinical presentation is molar gestation, while typical clinical presentation is missed abortion. So the patient will come with missed abortion. In FMG, they can give you a case of missed abortion. You'll see the patient had missed abortion. And other things, but at last the diagnosis can be partial mole. Partial molar pregnancies was there. Okay, so investigation that should be given in these molar pregnancies. First of all, diagnosis is done in the first trimester because of the routine use of serum beta HCG as measurements, as they produce excess beta HCG due to trophoblastic proliferation. Because beta HCG is secreted by trophoblasts, and there will be excess secretion of HCG, and also in TVS. Although beta HCG levels are helpful diagnosis of molar pregnancy, frequently is done by sonographically because of the identifiable diffuse swelling and enlargement of chorionic villi. Very important. Diffuse swelling and enlargement of the villi, villus stroma. This can be seen in TVS, transvaginal sonography, and we can this can be visualized in TVS easily, and we can diagnose. We can diagnose hydatidiform mole. Appearance on the USG is the term is snowstorm appearance. Snowstorm appearance, very important. You must remember this. Treatment is suction curettage is the preferred method for evacuation regardless of the uterine size in patients who wish to remain fertile. Suction curettage. Gestational trophoblastic neoplasia GTN develops after approximately 15 to 20 of complete moles and 2 to 4% in partial moles. Post-molar surveillance with serial quantitative serum beta HCG levels is standard, and GTD means gestational trophoblastic disease includes hydatidiform mole, invasive mole, choriocarcinoma, placental site trophoblastic tumor. Most common site of metastasis of GTD, lungs. Must remember. So these are some of the quick facts, and must remember very important facts for FMG. So this is about hydrotherapy form, mole, complete mole, partial mole, their differences, previous diagnosis. Okay. So next question is theca lutein cysts are seen in complete mole, partial mole, tubal, ectopic, mixed abortion, and the answer is complete mole. Theca lutein cyst. Theca lutein cyst is basically they are yellow colored cysts seen in H mole, means hydrotherapy mole due to high circulating levels of ACG. So theca lutein cysts are yellow colored cyst. And they are also seen in case of fetal hydrops, placental hypertrophy, multifetal pregnancy. These three. Okay, next is revision of zygote took place on 5th day after fertilization. What is the type of twinning? What is the type of twinning? Monochorionic or monoamniotic, monochorionic, diamniotic, dichorionic, diamniotic, dichorionic, monoamniotic. It will be monochorionic, diamniotic. Division of zygote took place on 5th day after fertilization. If the division of zygote occurs 72 hours to 3 days, then dichorionic diamniotic. Between 4 to 8 days, monochorionic diamniotic. Between 8 to 12 days, monochorionic monoamniotic, and more than 12 days, or more than if it is more than many days after, then Siamese conjoined twin occurs. Okay. So most common type of twinning is dizygotic twin, which is 69%, while monozygotic twins are 31% occurrence. Most common type of twin gestation is diamniotic monochorionic. Diamniotic monochorionic. This one only. Most common type of twin gestation. Least common type of twin gestation is conjoined, less than 1%. Prematurity is the commonest fetal complication. Prematurity is the commonest fetal maturation. Postpartum hemorrhage, PPH, postpartum hemorrhage is the commonest maternal complication. Very important. This commonest complications, fetal complication, maternal complications, very important. Must remember in any case and every case. Like commonest fetal complication is prematurity in this case, whereas commonest maternal complication is PPH. Okay. With the next question, triad of ectopic pregnancy. Very important question again. Triad of ectopic pregnancy are all except vomiting, bleeding, abdominal pain, amenorrhea. The answer is vomiting. Classic triad of ectopic pregnancy. Ectopic pregnancy, always remember, this is the triad of ectopic pregnancy, that there will be lower abdominal pain, not necessarily lower abdominal pain, pain in abdomen, amenorrhea because pregnancy has started, no, and bleeding per vaginum, PV bleeding. Now why amenorrhea occurs? Because pregnancy has started, but pregnancy is not in uterus, not in the normal side. That's why uterus cavity will be empty. In ultrasound, it will shown to be empty. Okay, but pregnancy has occurred in some other places. Okay, this triad is present only in 50% of cases. 50% of cases of ectopic pregnancy. This is also again another important thing. Most common consisting finding of ectopic pain. Ectopic pain. Not lower uterine, maybe in the abdomen. Wherever this ectopic pregnancy is occurring, there it will be pain. But ectopic pregnancy mostly occurs in the outside the uterus also, outside wall of the uterus, or in the fallopian tube, outside the wall of the fallopian tube. Okay, it can occur in any side actually. It can occur in other sites like in the upper abdominal places as well. Symptoms: nausea, vomiting, lower abdominal pain, or generalized abdominal pain if this implantation has occurred in some other places. But mostly lower abdominal pain only occurs because most commonly it occurs in outside the uterus wall or fallopian tube. That's why. But not necessarily in the lower abdominal pain. Wherever the pregnancy is occurring, if it is in the outer wall of the uterus, then lower abdominal pain. Fallopian tube, almost lower abdominal pain. If it occurs in the upper abdominal areas, then pain will be in the upper abdominal. There will be upper abdominal pain will be there. Okay. So accordingly, it will occur, not necessarily lower abdominal pain. That's why it can be generalized abdominal pain as well. Syncope attack can occur. Shoulder tip pain may occur. This is referred pain actually due to intra-abdominal pregnancy. So ectopic pregnancy occurs inside the endometrial lining of uterus. And the major health risks of ectopic pregnancy is rupture. So what is the problem? The problem is first of all pain. And the biggest thing is if the pregnancy occurs other than the normal site, the normal growth, normal nourishment, and the normal process of embryogenesis cannot occur. And most commonly what will happen is rupture of the products of conception, or the rupture of the pregnancy, not products of conception, sorry, rupture of the pregnancy, and it leads to internal bleeding. So if the pregnancy is stopped, because it ruptures, pregnancy ruptures, the whole components along with the implanted blastocyst and the embryo ruptures, and there will be bleeding, internal bleeding. Now everything stopped, right? Everything stopped. That is why there is no trophoblast cells, because it has ruptured, it has destructed, and no trophoblast cell, no beta HCG secretion. That's why beta HCG will not rise as fast as in the uterine pregnancy. It can also be diagnosed by pregnancy test, but a negative pregnancy test doesn't rule out diagnosis of ectopic pregnancy. On TVS, there will be presence of adnexal mass and absence of intrauterine pregnancy. So there will be presence of adnexal mass, but intrauterine pregnancy will be absent. DOC for ectopic pregnancy is methotrexate. And diagnosis can be done by, most definitive diagnosis can be done by demonstration of the intrauterine sac. Intrauterine sac will be empty. Empty sac, right? Empty sac. Transvaginal TVS. So the patient has complaints of pain. Patient has complaints of pain. There is bleeding. There is positive pregnancy test. So pain, bleeding, positive pregnancy test. But then we will do TVS. Then we will go for TVS and we will see intrauterine sac is empty. widow's TVS, and IU sac empty. It implies ectopic pregnancy. Pregnancy is there because you see the symptom, these features. Pregnancy is there, but IU sac is empty. That means somewhere else ectopic pregnancy. Okay. A positive test only confirms pregnancy but does not indicate whether it is IU or U, means extrauterine, ectopic or intrauterine. Doesn't confirm that. In normal pregnancy, beta HCG should double up every 2 days, but in ectopic pregnancy, the rate of increase of beta HCG is slow. Caltosynthesis is transvaginal passage of a needle into the posterior cul-de-sac in order to determine whether free blood is present in the abdomen. This procedure will reveal non-clotted blood if intrauterine abdominal bleeding has occurred. Clotted blood signify ruptured ectopic pregnancy. And if caltosynthesis is positive, laparoscopy or laparotomy should be performed immediately. Okay. So when we will go for medical management of ectopic pregnancy using methotrexate. So if there is hemodynamic stability, if there is no evidence of acute intra-abdominal bleeding, reliable commitment to comply with the required commitment to comply by the patient compliance is there and follow-up care is possible, then only we can go for medical management. These are some preferable requirements. Okay. Next question, trichomoniasis is caused by bacteria, virus, protozoa, chlamydia, and the answer is protozoa. What happens in trichomoniasis? There will be pruritus, itching. Pruritus. Patients mostly complain of pruritus. Infection is sexually transmissible and can be acquired. Not uncommon during pregnancy and is often associated with gonococcal infection. Very important. Trichomoniasis is a protozoan actively motile and is anaerobic. Trichomonas vaginalis is the type of trichomonas found in vagina. Symptoms: 20% remain asymptomatic, 70% show profuse, thin, creamy, or slightly green in color, irritating and frothy discharge. So, pruritus and green colored, remember this green colored discharge. Green colored frothy. Green colored and plus frothy discharge. This nature of discharge is very, very important. Frequently this type of question comes in FMG. They will give case and they will give very prominently, they will give the nature of discharge. With the nature of discharge only you can understand. Green colored frothy discharge, trichomoniasis, protozoal origin. Another important condition is strawberry vagina. Often multiple small punctured strawberry spot. Strawberry vagina, very important. Strawberry vagina. Urinary symptoms such as dysuria, frequency and low-grade urethritis, abdominal pain, low backache, and dyspareunia. Dyspareunia, pain during intercourse. This is pain during intercourse. Dysuria, pain during urination, frequent urination, low-grade urethritis, with low-grade fever also, abdominal pain, low backache. If so, all these things can occur if there is pelvic infection along with trichomonial infection. So very important topic, trichomoniasis. Diagnosis should be culture. Treatment: metronidazole, And recent modality of treatment is shorten the duration of the therapy by giving 2 gram metronidazole for only 1 day. Single dose. 2 gram metronidazole. Otherwise, another regimen is 200 mg oral, obviously oral tablet TDS for 1 week. For both partners, another important, very important thing. Both partners, both metronidazole. Okay. Okay. So next question: all of the following statements are true about bacterial vaginosis except caused by Gardnerella vaginalis, fishy odor upon whiff test, infection seen when vaginal pH is less than 4.5, and it is not an STD. So all of the following statements are true about bacterial vaginosis. So except which one? So in bacterial vaginosis, it is caused by Gardnerella vaginalis. Fishy odor, very important, fishy odor will be there on whiff test, and not an STD, not an STD. These are all true. Now vaginal secretions will be of gray color, thinly coat the vaginal walls. pH is higher than 4.5, not lower. This is incorrect. It will be higher than 4.5, especially 4.7 to 5.7. Microscopy reveals that an increased number of clue cells, leukocytes, are conspicuously absent. Very important. Addition of KOH, potassium hydroxide, to vaginal secretion, that is the whip test, right? Where KOH plus vaginal secretion. This is whip test. This is whip test. And this gives fishy amine-like odor. Fishy amine-like odor. It confirms bacterial vaginosis. Most common vaginal infection during pregnancy is candidiasis. Most common vaginal infection during pregnancy is candidiasis. Very important fact. Most common vaginal infection during pregnancy is candidiasis. Bacterial vaginosis is the most common vaginal infection in women of childbearing age. Bacterial vaginosis. And genital human papilloma virus is the most common sexually transmitted infection. Genital human papilloma virus. Human papilloma virus. Okay. HPV. Genital is the most common STI. Most common STI. And this is not STI, obviously. Bacterial vaginosis is caused by Gardnerella vaginalis. Okay, in patients with asymptomatic carrier of chlamydia, organism resides most commonly in. So asymptomatic carrier of chlamydia. So organism is residing but not causing, not showing the symptoms. So it is residing somewhere. Somewhere means most commonly in vagina, urethra, ectocervix, endocervix. And the answer will be urethra. Chlamydial infection common in young sexually active women. Chlamydial infection is common in young sexually active women. Do remember this. Very important. Very important for solving some cases. It will give you at least a clue that chlamydial infection. The incubation period is 6 to 14 days, which is and sexually transmitted by vaginal or rectal intercourse. Chlamydial trachomatis is a small gram-negative bacteria obligate intracellular parasite. Small gram-negative bacteria obligate intracellular parasite. Good. Good fact for a microbiology that appears as intracytoplasmic inclusion body and is of two varieties. One that causes LGV, lymphogranuloma venereum, and other is non-LGV, which causes non-specific lower genital tract infections. So the infection is asymptomatic but may develop vaginal discharge, dysuria, frequency micturition, and at times cervicitis. So chlamydial infection, first of all, do remember, common in young and active women, sexually active women and young, transmitted both by vaginal and rectal course, and infection is asymptomatic but develop vaginal discharge. If symptomatic, then there will be vaginal discharge, dysuria, frequency of micturition, and maybe cervicitis. In asymptomatic cases, what happens? Chlamydial resides most commonly in urethra. Chlamydia resides most commonly in urethra. Sometimes chlamydia may cause Reiter's syndromes with arthritis, conjunctivitis, genital infections associated with skin lesions. Cervix is the first site of infection. Cervix is the first site of infection. Ascending upward causes salpingitis and infertility. That means cervix is the first site of infection. If it ascends upwards, then it will cause salpingitis and may lead to infertility as well. Diagnosis: use of fluorescence conjugated monoclonal antibody in immunofluorescence test. So immunofluorescence test should be done, and these samples should be taken from urethral and cervical secretions. It allows for direct diagnosis for the infection, direct diagnosis of the infection. Treatment is through treatment tetracycline 500 mg. Very important, this treatment. Clindamycin 500 mg 6 hourly into 2 weeks. Okay. Okay, so this is about chlamydial infection. Very important, and each of these facts is very important. Okay, next question. Clubbing of femoral endofallopian tube is seen upon HSG. Hysterosalpinography. What could be the possible pathology? Clubbing of femoral end. Tuberculosis, gonococcal, hydrosalpinx, Mullerian anomaly. And the answer is hydrosalpinx. So hydrosalpinx causes due to chronic pelvic inflammatory disease. The fine fimbria and tubal ostia are obliterated and replaced by smooth clubbed end. The ballooned thin walls of elongated tube are whitish and translucent, and the tube is typically distended with clear serous fluid. So fine fimbria and tubal ostia are obliterated and replaced by smooth clubbed end. Ballooned thin wall of elongated tube are whitish and translucent, and the tube is typically distended with clear serous fluid. So you know this fimbria will become clubbed because there will be distension. Distension is caused by distension is caused by clear serous fluid. Clear serous fluid. Depending on the degree and location of ipsilateral ovary, the hydrosalpinx may be adhered to. Hydrosalpinx is found in asymptomatic women during pelvic examination or incidentally during sonography or HSG done for other indications. Some women note infertility or chronic pelvic pain. So treatment is for women who has no intention to preserve fertility. We can go for laparoscopic treatment. We can go for laparoscopic treatment, which can include lysis of adhesion and self-injectomy. So adhesiolysis, number 2, self-injectomy. In women who desire fertility, surgical intervention depends on the degree of the tubal damage. Who desire fertility, then we go for surgical intervention depends on tubal damage. If hysterosalpinography is the study of patency of the fallopian tube, whether it is obliterated or not. Obliterated means the lumen, this is the patent lumen. There is lumen preserved, and if lumen is not preserved, then it is obliterated. So whether it is patented or obliterated, we need to go for hysterosalpinography for checking infertility. It is used in diagnosis and diagnostic value for infertility, and post-operatively we can go for tuboplasty and also employed to study uterine anomalies as well. This is the use of hysterosalpinography. Okay, so this is about the treatment of the hydrosalpinx. Okay, next, PID, very common, very important question. PID can be due to IUCD insertion, oral contraceptive, condom, hypertension. So it will be IUCD insertion. These are the risk factors of pelvic inflammatory disease: douching, single status, substance abuse, multiple sexual partners, lower socioeconomic status, recent new sexual partner, younger age, other sexually transmitted disease like sexual partner with urethritis or gonorrhea, previous diagnosis of PID, not using mechanical and chemical contraceptive barriers, endocervical testing positive for Neisseria gonorrhea or chlamydial trachomatis. All these are risk factors for PID. So IUCD, what happens? IUCD, intrauterine contraceptive device, acts by causing local inflammation. Basically it causes local inflammation